I'm going to present the first speaker. You probably all know who he is, because he's a very important person in hyperthermia, is Professor Bodis. He is going to speak about it's time for prime time for oncologic hyperthermia thermotherapy. He is working in different places: Canton Hospital, Arau University Hospital, Zurich, and the ICHS Foundation in Zurich. And I'm very, very happy to have you here today. So please, Professor Bodis, go ahead and we will listen carefully to your presentation.
Thank you very much, Elizabeth. Thank you very much, organizers, dear organizers, and thank you very much to all of you who attend this meeting. It's a privilege and a pleasure to be here. Do you hear me clearly? Do you see the slides?
Yes, we see the slides properly.
Perfect. So I think I would like to give a very positive message today. I thank Professor Arroyo, Elizabeth, for her very empathic words. Yes, we are in a difficult situation, but I think jointly we can manage it, and if we stand together, we are stronger. This is also true for hypothermia. I put a small question mark, but I think it's a good time now to look and to think and to push oncologic hypothermia and thermotherapy, these are both terms, into prime time. I would like to thank the co-authors here, and I would like the institutions who supported us. A special thank to Niloy Datta. Conflicts of interests, I declare here briefly. Now, what is important, we don't need 500,000 people to push hypothermia in the direction we think it's best, with empathy and with evidence-based medicine. We need 2 strong united leaders or 2 strong united groups, and that's enough to push our field forward one step further. What I think is also important, use discussions with your national leaders in healthcare, not only in oncology, and try there to promote your ideas in oncologic hypothermia and thermotherapy. And here maybe we can quote Cato's Cetum censeo Carthaginam delenda messe, but it should be much more positive and with a constructive and not a destructive content. So in Switzerland, how do we handle oncologic hypothermia? You know, we have a lot of pros, but we have also our challenges and our downsides. And it's kind of a material method slide. So Swiss hypothermia thermotherapy in the network is embedded always in the Swiss radiation oncology unit. We use infrared and radio frequency wave for superficial hypothermia and radio frequency waves for deep hypothermia. We use fractionated, moderate heated regional thermotherapy in combination with radiotherapy. Then we have a planning library for specific tumors in defined anatomic regions for deep hypothermia. And we use experimental, personalized, RT-like specific planning for deep thermotherapy patients combined with proton therapy. Then we also use online temperature point measurements only at the tumor and the surrounding health tissue. So you see where we stand. There are many institutions who do more. It's kind of a common consensus which we can use now, but things are in progress to move on. So the message today would be probably these 7 bullet points. We need evidence-based medicine. That's true for all the 6 remaining points too. We need now timely, modern, multicentric, prospective randomized clinical trials. I will elaborate on this a little bit more. I think we should look and need ISO certification for our clinical thermotherapy units. This is open for discussion then. There is also need for clinical European research networks that we integrate or we construct our own networks with the focus on thermotherapy, hypothermia. There is a need for reimbursement for defined indications. We cannot live from science alone. We need to bring them to patients, and for a credible patient treatment, we need to have a reimbursement. Then there's also a need for better and further standardization of hard and software in our field. and the need for standardization of patient workflow and QA. So I will briefly elaborate on these 7 points. Need for evidence-based medicine, that's true for everything. But instead of giving you now a catalog, which you all know, I rather recommend that, as we did it, make your own SWOT analysis for your institution. So to get into prime time, to make hypothermia solid with evidence-based medicine, where do you see your strengths, your weaknesses, your opportunities, and your threats if you push hypothermia thermotherapy further? Try to do that, and it might help in a strategic way to become stronger and to build up a better network. Now, from the strengths, from the evidence, I think we will discuss clinical trials and meta-analysis a little bit later. But here I would also like to make a statement that for the technology, for the individualized treatment, which is such a prime word now, also for pharmaceutical companies, but also for commercial issues, we might look into 2 ways. One is probably have a customized catalog for technology which is suitable for specific body locations. But maybe there are also more universal system needed, modular system needed, for example, also for the use in LMI countries. So maybe this is something which you could think about for the near future. The next thing is, we do have clinical evidence from randomized trials. We do have these trials, which are published sometimes many, many years ago, but they're still very heterogeneous. But despite the heterogeneity, the outcome is clear, at least if you compare a pair like radiotherapy hypothermia versus radiotherapy alone for all of the outcomes which were looked at. But it's also clear, completely different to chemotherapy and also different to modern targeted systemic treatments. We do not have an added long-term side effect if we add hypothermia, regional moderate heated hypothermia to radiotherapy. And this is a big plus if you talk to patients, if you talk to families and to primary care physicians. And the next is maybe we have very, very prominent publications in Lancet Oncology, in JAMA, and the New England Journal of Medicine, maybe many years ago. And these publications should be used, for a first discussion with your opinion leaders or with healthcare responsibles who look into new acceptance of new modalities for reimbursements. So, for example, what we have now, based on excellent work of our previous generation of previous leaders and current leaders in the field, we do have reimbursement for defined indications, for example, in the Netherlands and in Switzerland. In Germany now, for 3 years, it's mandatory that every sarcoma. Also, since 3 years now, there's reimbursement in the Netherlands for abdominal metastasized ovarian cancer and HIPEC. So what is needed maybe for next year, to give a stimulus? I think still the prime goal should be randomized, prospective, multicentric phase 3 trials with long-term follow-up. They should be international and they should have defined endpoints, because meta-analyses are fine, but they can always close a gap for a certain time. And the critical point for all healthcare politicians and for our colleagues and not so big colleagues in the field of oncology is always, where are the data based on international multicentric prospective randomized phase 3 trials with a long-term follow-up? We also need phase 1-2 trials. This must be clear, but they should be innovative and they should either look at better outcome, better efficacy, or more value for the same patient fee. And there we have 3 fields, that all. Local regional, moderate temperature hypothermia thermotherapy, eventually now combined with proton therapy, or even more interesting from a scientific perspective with flash radiotherapy. Then we systematically and better should look at the 3-modality treatment with immunologic therapies, with customized molecules and or radiotherapy and hypothermia thermotherapy. But there should also be room for novel low-budget state-of-the-art radiotherapy and maybe low-budget thermotherapy, which can be used in our centers in North America, in Asia, in Europe, but maybe also in low and middle income countries who do not have the same budget as we do. Then a second field for innovative treatment, phase 1-2 trials, is local high temperature ablative hypothermia thermotherapy. This is often discussed in a totally different background. And I think our leaders within our societies have to decide how and how much we can integrate into a common background. And there is also the field of whole body low to moderate hypothermia in the oncologic setting, and very interesting right now for novel applications like for multi-resistant bacterial infections. There is a strong call, for example, from the NCI, that chemistry, antibiotics come to an end, and physical treatment in multi-resistant bacterial infections might be a future. The next bullet point is, if you have the resources, please look if you can have an ISO certification of your units. I will be brief here, but there are two important statements from our center where we did it. With the certification, we immediately increased acceptance of our treatment by the CEO, the CMO, quality management, and hospital administration. It was a scientific tool of completely unknown effect before, and it jumped into a certified medical device. And comments from our opinion leaders, only in our small area, were this was a good step for you. Now we start to consider hypothermia thermotherapy more seriously, not immediately accepted, but more seriously, that's fine. And we understand now that you don't harm patients. So those were three important statements with the certification and the communication of this process. So, need for international hypothermia and thermotherapy research networks. That's the next bullet point. And I can only give you an example from our Swiss Hypothermia Network. You have other big achievements, and this is just an example, what we did and what we plan maybe for next year. I think for the Swiss Hypothermia Network, an Astro endorsed workshop to promote endorsed European clinical trials was an important step. We are not there where we expected, namely to launch a European or even a bigger trial, phase 3 trial, which is endorsed by all major players. But I think it was a step in the right direction, and I hope the next leadership will now take this ball up and that we will be successful. And a very good next small step in this direction was a joint forces meeting between the Astro Clinical Trial Committee and the Atzelsberg Group. For me, it's critical that this is a completely open platform, open to everybody interested, no restrictions. The next good news, I think, was last year from Hans Griesi-led EU Horizon 2020 grant, hypothermia boosting the effect of radiotherapy. This was a major achievement, and I will just show you a few slides afterwards. Many of you know this, but it was also increasing acceptance of science, the quality of science immediately in the field of, say, oncology research in Switzerland. Then this year, I think we had the pleasure and privilege to have a interdisciplinary symposium on oncologic hypothermia during Astro. And this was really a good open joint session with leaders from Europe, Asia, and the US, with a symposium titled Current Status of Hypothermia and Radiation Oncology. It was well attended, and we had a lot of good feedback. And next year, we were invited for a special edition of Cancers, an issue dedicated only to oncologic thermal radiotherapy, where we have the privilege with Piero Scadia and Gerard van Roon try to help and coordinate the manuscripts. So for HyperBoost, just briefly, this slide, the unique thing for me and the very precious thing is that it's broad international within Europe, and we have players from academic centers, from private centers, and from industry. And I think this is the way to move forward, that within industry and with the different players of maybe clinical oncologic hypothermia, thermotherapy, you define what is common and you define what is not common, and you try to strengthen the efforts for the common interests. This is briefly the outline of the Astro Symposium. Jens Overgaard made an opening mark. He was one of the really fathers for this field. I think that was very well accepted. And then we had scientific contributions from Hans Griesi, Hideyuki Sakurai from Japan, and Seiko Miyaskovic from the US. And an honor for us that as the current Astro president was concluding that yes, hypothermia is interesting and it's moving, I think that's where this was, towards prime time. And this is just the specialist of cancers. This will be out probably by spring 2022. So need for reimbursement. Here I would like to show you two slides, one from the Netherlands and one from Switzerland. You see a graphic in the middle. I would like to thank Professor Data for this slide. There you see that the green, dark green areas in Europe have rather a good reimbursement level, like the Netherlands, like Germany, Switzerland, and there are others like Poland, like Sweden, like Italy, who have a reasonable reimbursement, but it's very tricky to get it, and it's very difficult to expand it. And if you're nothing, the first step is always the most challenging. So I think here I would like just to tell you, Netherlands can be a very good partner for you to get more information. They have this list, which is displayed here, of reimbursement. And I will go more into detail for Switzerland. The current status, it changed this year. We have now 4 indications which are mandatory and must be reimbursement for any outpatient treatment for superficial hypothermia in combination with radiotherapy. For the curative settings, this is recurrent melanoma, head and neck cancer recurrences if pre-radiated, and chest wall breast cancer recurrences if pre-radiated. For the palliative setting, for superficial hypothermia, it's local tumor recurrence with compression symptoms. We have now this was very challenging because it's a much higher price for reimbursement, 2 indications for deep hypothermia, which are unlimited approved now, cervix cancer if there is a contraindication for concurrent chemoradiotherapy, and palliative painful bone metastases of spine and pelvis. This is thanks to the data from Taiwan for our colleagues. A big thank you to Taiwan for this excellent paper. Then we have 2 indications for deep hypothermia, which are now approved for a 2-year term. Curative soft tissue sarcomas to preserve anatomical function. And it must not be in clinical trials. And what is very interesting maybe to you, proton therapy is encouraged to be used. And for the palliative setting, it's local tumor recurrence with compressive symptoms. Important is that all these indications are restricted to synchronous state-of-the-art radiotherapy. The patients must be presented at the local tumor board in a certified oncology center, and the decision must be in written. And the Hypothermia Thermotherapy Center must be an accredited member of the Swiss Hypothermia Network. So this is briefly the status in Switzerland this year. Now I will finish up soon. I think there is need for standardization of all clinical used hard and software. This is very important, I think, for us clinicians. Please help us, experts from medical physics, IT, MTRs, RTTs, whoever is an expert. And it becomes even more important if we integrate non-invasive thermometry and planning with MRI. Now a specific point I would like to mention here. It's not a real software, but we need a standardization of our language, of our vocabulary. We need a glossary, an encyclopedia dedicated to hypothermia thermotherapy. I think there are many activities in progress. We should harmonize our technical terms. We should harmonize our keywords. We should create new and commonly accepted terms where needed. Because it's so crucial for the promotion of global hypothermia thermotherapy that our language is understood and accepted by all stakeholders. Patients, families, primary healthcare. If we start to debate in a tumor board, if hypothermia is heating to a certain degree or it's an area under the curve and what is SAR, no chance. A primary healthcare physician, a medical oncologist listens a minute. And if we start to debate about these terms and we don't agree, we're out. And I think this is only possible with a joint effort of all providers in research and from industry. And I think we make a good effort and this should continue. I think there's also need for standardization of workflow and QA, need for accepted international guidelines, and this also should be coordinated with industry, manufacturers, national guidelines, and maybe ISO certification others. So to conclude, as an oncologic underdog, which we still are, but with a strategy and a vision, what we should take care now is, I think, evidence and empathy. This is clearly number one. No evidence without empathy, no empathy without evidence. We also need to push quality and outcome analysis. And I think this is also the goal of this platform here, increase, strengthen our cooperation and communication efforts. And then we push hypothermia thermotherapy into prime time. So thank you for attention. Unified, I think we have all chances to face the shark. and I'm happy to take questions. Thank you again very much for the invitation and the time dedicated. Take care.
Okay, so I'm going to put my camera. So thank you so much, Professor Bodis. It's always wonderful listening to you. Your lecture, I think, is very, very interesting from someone with so much experience in this field of hyperthermia. And I think you have said very important things. I agree with you that we have evidence, but the problem is that we don't show to the world that evidence, and we need to join efforts for research. I think that is very important. It's interesting to me your first slide with that slide from the two strong leaders are enough to change things, and I agree with you that we don't need a lot of people, but we need that the ones that we are working on this make efforts to go on moving forward. So I think it's really, really interesting, and I always follow your steps because I think it's interesting that in Swiss, Germany, the situation of hyperthermia is much better than, for example, in Spain. And I would appreciate if you could give us some advice about how to maybe begin convincing our politicians to say, okay, we need to put this treatment here because it has to be a standard in some of our patients. So I don't know if you have any advice for all the other countries which are trying to get hyperthermia and a standard treatment for some cancer patients.
With pleasure. You know, there is no advice because we struggle probably much more than it looks like in these slides. Actually, hypothermia was kind of silently reimbursed in selected situations based on health insurance, and this suddenly stopped. And this forced us to make all this effort. Without cutting things, we would probably not be there. And this was only possible, I think, due to really excellent work, dedicated work from our team. Nilo Datta helped us a lot while he was in Aarau. And I think every country has its own mixture, but for us it was helpful to contact pharma companies, people we knew, their scientists, and said, what do you do when you have a new compound? You know, how do you start the discussion with healthcare politicians for a process of approval? So that was helpful. And we approached Radiation Oncology Society of Switzerland and the Medical Oncology Society of Switzerland and asked them if they would be willing to set up a roundtable for discussion so that they would also endorsing kind of this step. So these were two preparation steps. And then again, it was key persons. You know, we were lucky to find a key person in the Swiss Ministry of Health who said, I think this is interesting, but you guys made a lot of mistakes. So I help you to go through that. And why do I help you? Because you're not endorsed by industry. So that was probably what we had. And I don't think there's a recipe, but I'm more than happy to share things in a more detailed way if this is helpful at some point.
Yeah, that is great. I think that maybe we can try to join different situations of different countries and with different experiences to go moving forward.
Maybe one word, Elizabeth, just at the end, so that there are no disappointments. For all decisions which were unlimitedly approved, it was crucial to have a randomized, multicentric, timely phase 3 study with long-term follow-up. No way without this.
Sí, me quedo yo. Si quieren, me da igual. Ahora, de todas formas, que venga Fernando, no.
I'm going to. Yeah, sorry, because there was someone speaking. So we have a question from Dr. Van Gogh. I don't know if you want to speak or I can ask your question. I'm going to give him 1 minute. Yeah.
Yes, we cannot study all different types of cancers, of course, in randomized prospective clinical trials. That's simply impossible. But if we would stress more on this new term agnostic treatment, it might maybe a possibility to prove the evidence really in appropriate prospective randomized controlled trials, and then claim that the technology can be translated to other cancer diseases without doing for each cancer disease a proper RCT on its own. I would like to hear your comment on that.
That's an excellent question and a very challenging one. I'm happy to take this up. I give you an answer which is wrong, but it's probably the answer I can give now. Based on the discussion we had with the Swiss Ministry of Health, I would say out of my belly that yes, you're right in one way. We probably can do this now with palliative care. For palliative care, we don't need a specific tumor. We don't need a defined number of metastatic sites. Probably bone metastases will be a little bit different, but there all indications have room based on the palliation. That means there is a pre-radiation in this area and the patients suffer for compression symptoms and there is no other modality. And out of these trials, we can learn to extrapolate. That's a not very good answer one. The second is we need 5 indications. That's my gut feeling. We need to prove in 5 randomized phase 3 studies for the most common solid adult locally advanced tumor sites that we have a positive result. And then I think your step might be possible. So this is my answer at the moment, which is incomplete, which is partially wrong, and I'm happy to take a re-challenge from you.
Great, so thank you so much, Professor Bodis.